everyone. Welcome to the Rare Info series by Organization of Rare Disease India. Today we have Dr. Atanu Kumar Dutta amongst us, and we are fortunate enough to have Sir with us. And Sir is additional professor in biochemistry in AIIMS Kalyani. Sir has done his MBBS and MD in biochemistry. He has done postdoctoral fellowship in clinical geneticists. And I love to say that in West Bengal, he is one of the pioneer in clinical genetics research. And Sir is having total 17 years of experience in this field. And Sir is a teacher in many prestigious courses throughout India. He is teaching in DNB Medical Genetics, DM Neurology, DM MD Pediatrics, MD Biochemistry, MBBS course, Nursing course, BSc and MSc in PGI Chandigarh, in IPGMER and SSKM Hospital Kolkata, as well as NIBMG Kalyani, AIIMS Kalyani, and CMC Vellore also. And you will be happy to know that Sir is having an H index of 16, which is very high indeed. So welcome, Sir. Today, Sir will speak on newborn screening, the first line of defense against rare diseases. I often say that catch them before they can. Yes, sir. We want to do that. And welcome, sir. Now all the audience is yours only. Sir?
Thank you, ma'am.
Okay.
Thank you for the kind introduction. I will share my slide. I think my slides are visible.
Yes, sir.
Yes, sir. Visible.
Thank you. Okay, so I have chosen this topic because I think this is the need of the hour for our country. We need a universal newborn screening program throughout the country. So I will argue very strongly about that in my presentation. It's not going forward. Just a minute. I will stop share and share again. 1 minute. I think it is visible now. It is moving.
Yes, sir.
No, it is again not moving. Just a minute. Why it is happening then? Now it is moving. Is it visible now?
Yes, sir.
Thank you. So I'm sorry for the glitch. So screening is definitely a preventive process. It is not a diagnostic process. So we want to diagnose early those disorders which are easily treatable, and so that we can prevent morbidity and mortality in the child. So typically the newborn screening is based on the collection of blood from the heel prick. So it is a very small invasive process, and a few drops of blood is only necessary, but it can prevent life-threatening consequences if it is not done. So this is a history of newborn screening, how it started in 1961 by Dr. Robert Guthrie. So he was a chemist and his own child was affected with phenylketonuria. So he developed a bacteriological test based on which he diagnosed phenylketonuria based on the very high phenylalanine level in the newborn child's blood. And this was quickly propagated throughout the US. So in 1962, a national program was launched in USA based on the Guthrie card method. The WHO also embraced the same method in 1968, but it took some time for this to come to India. So in 1982, this was started by Dr. Meena Desai about screening for thyroid stimulating hormone for congenital hypothyroidism from the cord blood. So congenital hypothyroidism can be screened by cord blood also, but not for all analyte. So cord blood is not a very good analyte for biochemical screening for other diseases. For that, the heel prick blood is actually necessary. And this was started in BGCI hospital in New Mumbai. Then after the Western India, in Southern India, from Bangalore, Dr. Appaji Rao and colleagues, they started the newborn screening program in 1988. Then again, there was a hiatus for around 20 years. After that, the ICMR launched a major program where there was 5 centers in India who screened more than 2 lakh newborn for congenital hypothyroidism and congenital adrenal hyperplasia as well as the glucose 6-phosphate dehydrogenase deficiency. So those 5 centers were chosen from 5 corners of the country, and this study actually gave the prevalence statistics of those disorders. So once those statistics were available, then a few states and union territories, they started newborn screening program. So it started with Goa. It was a very ambitious program. I'll come to that. Initially, it was for more than 50 disorders. It was screened, but then it was changed recently. Then 2011, the National Neurology Forum, they recommended that all the newborn across India should be screened for these 3 disorders. There is congenital hypothyroidism, congenital adrenal hyperplasia, and glucose 6-phosphate dehydrogenase deficiency. Then Kerala came into the fray in 2012, and the state has not looked back. They have expanded from there. So I'll come into some more detail on that. So the key components for any newborn screening are these few, that there has to be awareness in the community. That is the most important thing. So the awareness has to be multifaceted. It has to be there in the clinicians. It has to be there in the would-be parents, in the political establishment also, if they want to give the screening for the mass population. And then there is a need for timely collection of sample, trained professional infrastructure, as well as the long-term follow-up of those children who are screen positive. So how we decide that for which disease we need to screen? So that is based on this criteria which was given by Wilson and Jungler. So basically there are 3 points that we need to consider. One is the condition that needs to be screened. Second is the test which is available for screening, and third is about the treatment. So I'll come a little bit detail on that. So regarding the condition, definitely there is no doubt that these 3 disorders, congenital hypothyroidism, congenital adrenal hyperplasia, as well as the glucose 6-phosphate dehydrogenase deficiency, these 3 should at least be screened because they are very common in our population. So GXPD can be almost like more than 1% of the population, and in certain communities, for example, in tribal communities, is very high. Then congenital adrenal hyperplasia is also 1 in 5,000, and congenital hypothyroidism almost like 1 in 1,000. So these 3 disorders, definitely the prevalence is so high that this should be screened. And they can be actually screened and diagnosed much earlier than the symptoms develop. And we know adequate natural history of this disorder, that if we don't screen and treat, then what will be the outcome? So these are few research studies where they have looked at the prevalence of these 3 disorders. So you can see that glucose 6-phosphorus dehydrogenase deficiency is almost like more than 1% in few studies, and congenital hypothyroidism almost like 1 in 1,000, and congenital adrenal hyperplasia from 2 to 5,000. That is the prevalence statistics. Now, what are the characteristics of the test? So the suitable test should be available, and it should not have very high cost involved in that, and the sample should be easily collectible from a heel prick blood. And if the false positivity rate is high, that is not a problem, because every screening test should have high sensitivity. So it should not miss anything. So whoever is screen positive, then they have to be confirmed by a repeat test or another molecular method. So that is fine. But the most important thing is that the political commitment is required, that much of money should be available for the screening test. So now I'm coming to the one by one the different state programs which are there for newborn screening. So Goa program, there was a Goa 1 and Goa 2 program. So it started in 2008 and spanned up to 2013. So they screened around 48,000 newborn, who are almost 50% of the live births in Goa. So whoever was born in a government hospital was screened, and they have screened for more than 50 disorders. It was a very comprehensive screening. And the test was done both in public hospital as well as by the private hospitals also. But they stopped it after some time because the detection rate was low, as per the expectation was not that high. But then they again started in 2018. But they told that we do not need to screen for so many. Now they have reduced to 6. There's these three: congenital hypothyroidism, congenital adrenal hyperplasia, G-spore deficiency. Another three: galactosemia, biotinitis, and cystic fibrosis. And they say that if the child is high risk because of some family history or other comorbidities or illness, then they can expand to the previous one, that more than 50%, 50 disorder, they can be screened. The Kerala program started in 2012, and initially it was screened for 4 disorder, and then 2018 all births in all government hospital in Kerala, they are screened for these 4 disorders, and now they are planning to extend it to private facilities also. Chandigarh also started this program in 2017 in 4 government hospital, again for these 3 disorder: congenital hypothyroidism, adrenal hyperplasia, and glucose phosphate dehydrogenase deficiency. DBT wanted to expand the reach of screening for this disorder, and it established the Ummid initiative in 2019. So it has established 7 or more Nidan Kendra. One of them is in Kolkata also, in NRS hospital, for screening for treatable disorder. And also they also train the government medical college faculties so that they can start this screening test in their own departments when they go back. Now, Delhi government also started this NEEV program, that is Neonatal Early Evaluation Vision, where they again screen for these 4 disorder or 5 disorder, and they have initially started in 31 major birthing facilities, government facilities, and they now want to expand to all delivery points. But why only these few states, which are small to moderate size states? These are not major size states like UP or West Bengal, like these big states. So what are the hurdles? Why these big states are not able to implement the newborn screening? So the main problem the government says is they do not have the accurate epidemiological data that goes to all rare diseases, that they do not know what is the exact burden. So that is the main problem. So as we go along, I will show some research finding where we have generated some epidemiological data about the prevalence of this rare inborn metabolism in India. Then second thing is that the awareness sometimes is lacking. So typically the gynecologists, if they are not in a city hospital, in a rural setting, usually they do not counsel the parents regarding the need for and newborn screening for other than congenital hypothyroidism. I see that most of the gynecologists also and neonatologists, they ask for congenital hypothyroidism screening, but apart from that the others are not usually counseled that much. So awareness is somewhat lacking there also, and the most important part is the infrastructure is also, trained manpower is lacking to some extent. And the final thing is that absence of a national policy. So, for example, the national rare disease policy have changed the paradigm, how those disorders are diagnosed and streamlined for management. But we do not have a similar policy for newborn screening in India till now. The Rashtriya Bal Swasth Karyakram, they have done some screening, some things are there. For example, they cover 4 Ds: defect, disease, development, and disability for up to 6 years of age. So these are the list of diseases that they screen for any child who comes to a Rashtriya Bal Swasth Karyakram program. So I'll not list them, but I will discuss some of them as we go along. And then the National Neonatology Foundation, they have also classified newborns into 3 categories, A, B, and C. And based on the category, they actually tell that what kind of screening should be done. So category A is all the newborn, they should be screened for those disorders. Category B is only high risk, and category C is if they are in a research rich setting, then they can be undergoing expanded screening also, even if they do not have a high risk profile. So for category A, that all the newborn, they should be screened for congenital hypothyroidism, hearing screen, congenital adrenal hyperplasia, G6PD deficiency, and especially the G6PD deficiency should be there in the northern states, and sickle cell disease and hemoglobinopathy should be there in high incidence states. For example, West Bengal has a high incidence for beta thalassemia. Odisha, Jharkhand, Chhattisgarh, they are high incidence for sickle cell disease. So there, all the newborns should be screened for these diseases. Then category B, where if the newborn have some high risk like parental consanguinity, family history, seizures, unexplained sibling death, etc., then they have to go undergo an expanded screening where they look for other amino acidopathy like phenylketonuria, homocystinuria, alkaptonuria, other diseases like galactosemia, and other routine tests. Along with that, maple syrup urine disease, then fatty acid oxidation defect, tyrosinemia, etc. Then category C, so that is for well-to-do families. So it is almost like those 50 disorders, they can be screened for those. So this is a nutshell, the common diseases which are there in the both the basic as well as the expanded screening, where they are the screening test is can be either a analyte or a immunoreactive trypsinogen or a enzyme assay. And the sample is usually a dried blood spot. I'll come in detail how the dried blood spot should be collected. The most important thing is when it should be collected. So it cannot be collected before 24 hours, except for congenital hypothyroidism. So congenital hypothyroidism, the cord blood during birth also it can be collected. But for most of the disorder, the heel prick blood should be collected after 24 hours of birth and within 72 hours. It can be done after 72 hours also, but then there will be some delay. And the cutoff values I have listed there. Other than the biochemical analyte, there are few more things which are also very important. One is the screening for retinopathy of prematurity. So as the premature newborn undergoes oxygen therapy, there is reactive oxygen species formation and then hypoxia that leads to vasoproliferation. So that is a preventable cause of blindness. So all premature newborn, they should be screened for retinopathy of prematurity. Then other newborn who are having other problem like neonatal sepsis, etc. The other very important thing is the newborn screening for hearing. So 1% of all the newborn, they have some degree of hearing loss. So unless we diagnose it early, then we cannot institute a management and they will have major morbidity because of deafness and muteness, etc. So almost like 0.5 to 5 in 1000 neonates, they have sensorineural hearing loss, and all the newborn admission in the ICU, they have much higher risk of hearing loss. Another very easily done newborn screening is by pulse oximetry for critical congenital heart disease. So it can be screened very easily, and many critical congenital heart disease can be reliably screened by this simple method. So when we want to screen any newborn who is a graduate of NICU, that who survives the newborn period and are discharged from the NICU, so we have to keep in mind that they have immature enzymes. And so if we screen within that 24 to 72 hour period, we might miss some of those. So we need to repeat. Initially, if we take the sample before 24 hours, then we have to again repeat after a few days. And because the child is very sick initially, sometimes we forget that the past hearing screening should be done, etc. But they should be actually tested. And because they undergo many pharmacotherapy and they get IV fluid, sometimes there are false positive. For example, there can be high chance of detection of falsely detected carnitine deficiency. That is because of the hemodilation. So those things should be kept in mind. The gynecologists actually they play a very significant role. So all the expected parents they should be counseled beforehand so that they are very receptive once the child is born. That what is the need, so that we need to poke the child for a drop of blood. So the obstetricians are the first point of contact and they have a major responsibility, especially if they have consanguinity or previous history of a childbirth with similar problem. They should be screened. Now I'm coming to the sample collection, how the sample should be collected. So already I have told that within 72 hours the sample should be collected. And if the child is in a NICU or have received a transfusion, then we need to repeat it later on. So this is a dried blood spot card which is used for enzyme assay, typically for storage disorder. So as you see that this is a Whatman filter paper. You can see the circles are there. So actually these are measured sizes. So around 200 microliter of blood will be required to fill a circle. And because this is a quantitative enzyme assay, so unless we give the appropriate amount of blood, then the result can be either false positive or false negative. So the blood should be such that that single drop should cover the whole circle. If we give multiple drops to cover the circle, again that will be not useful. It will lead to rejection of the test. So this is another card that's used by NIMANS. This is for not for enzyme assay. This is for small analyte like acyl carnitine or amino acid profiling by mass spectrometry. So the collection is usually done from the lateral side of the heel. And before collection, the heel should be warmed and a sterile syringe should be used so that at least 2 millimeter depth of the prick should be there. Now, it is sometimes a little bit difficult to do because the child may not be very cooperative. So sometimes there can be smudging. So I'll show you that what are the other methods of collection if the heel prick is not actually possible initially. And once it is collected, then we need to air dry the card for at least 4 hours. And do not stack the cards one upon other so that there is some contamination between the cards. So ideally, we should be collected directly from the heel prick side. But if it is not possible, initially the healthcare provider who is doing that may not be very effective in that. So in these cases, from the heel you can collect in a vial, and directly from the vial you can take the 200 microliter blood in a pipette and then put. So that will be very easily done. And this can be a plain vial. Or even if that is not possible, then you can collect it from the vein also and collect in a plain vial. For some reason, if there is a delay or there is a confusion that whether it will clot or not, so then it is not optimal, but we can use some anticoagulant also. So if you want to do a enzyme assay, lysosomal storage disease, etc., or biotinidase G-spirit deficiency, then we cannot use a EDTA tube because it is a enzyme inhibitor. So then you have to use a heparinase tube. Otherwise, if you want to do small analytes, then ideal is the plain vial without any anticoagulant. There is otherwise, if it is not possible, second best option is EDTA. So these are the some points that we need to remember that what we need to do. So I'll not list or read all of those. Once it is collected and dried appropriately, then most important thing is we have to send it with a desiccant. So there has to be a desiccant so that many parts of our country during the monsoon or other season, the humidity is very high, and that can lead to improper drying of the DBS card, and that can lead to degradation of the analyte. So always we should send the sample in a Ziploc pouch with a desiccant. That is very important to do. So now I'll come to few cases just to show that if we do newborn screening, that what are the potential benefits, and if we are failing to do, what are the perils to that. So this was a child, this was a couple who came to us who are married non-consanguineously, and they had two previous male child. They died, both of them, due to cardiomyopathy at the age of 6 and 8 years of age. So we have not seen those child, but from the medical records, we can find that they had normal birth weight and normal initial development. But after 5 years, they had slow growth and they required frequent emergency hospitalization following a febrile illness when the cardiomyopathy was diagnosed for both of them. And when they were admitted in the ICU, they had hypoglycemia, hyperammonemia, increased liver enzyme, increased creatine kinase, increased urinary ketone. They also had hepatomegaly, cardiomegaly, cardiomyopathy, arrhythmia with shortened QT interval, as well as the fatty liver. Then both of them actually passed on to coma and died. So because we didn't know the exact diagnosis, we only had the parents to do a carrier testing. So what are the diseases which can lead to this kind of a feature of metabolic causes of cardiomyopathy? So top of the list will be the fatty acid oxidation defect. Other can be glycogen storage disease also, like Pompe disease, very important. Then other cardiomyopathy also, other lysosomal storage disorder, endocrine causes like congenital hypothyroidism again, and disorders of oxidative phosphorylation, some mitochondrial diseases also are there. So because we thought there is a high risk of genetic disease, so we performed a whole exome sequencing to find out if both of the parents are carrier for any particular disorder. And it turned out that both of the parents, they had the same mutation which is there in the transport protein SLC22A5, which is a carnitine transporter which helps in the absorption of carnitine from the intestine. So it is a primary systemic carnitine deficiency. So there is 25% risk of recurrence in all future pregnancies. So in the next pregnancy, amniocentesis was done. Unfortunately, this fetus also had the same mutation in a homozygous state. So now this was definitely a very bad news, and it was conveyed to the parents. But they wanted to explore if there is any chance that the child can be saved. If the child is born, then the child can be saved. So we went back to the literature and we found another case report of a child having similar, exactly same mutation in the homozygous state. And we found that up to 3 years, and the previous siblings also up to 5 years, they didn't have any cardiomyopathy. So we thought that if we can supplement acyl carnitine, the levocarnitine, then maybe the cardiomyopathy can be prevented. So this was explained to the parents, and we also discussed with the neonatologists, cardiologists, and pediatricians, and they decided to continue the pregnancy. And so before the child was born, we decided to do a newborn screening for this disease after the child is born, and immediately afterwards we should start the drug. So this is the gene which encodes a transporter which is helps in the transport of carnitine inside the cell, and there is a loss of function mutation which leads to cardiomyopathy, and it leads to sudden death during a recurrent illness. So this was the report of the newborn screening result, which was sent after 24 hours of birth, and immediately after collecting the sample, the child was put on levocarnitine. So you can see that the carnitine level is extremely low. It is like 50% of the lower reference range. So definitely the diagnosis was correct. So once the sample was taken, immediately before the report came, we started on levocarnitine. And after starting levocarnitine, again the sample was sent after 10 days. And this sample also we found that now with the supplementation, the carnitine level has come to exactly normal. But we need to keep in mind, but as the child grows, the carnitine dose has to be adjusted. So we again repeated the sample at 4 months, and at 4 months also it was normal, but it has come down. It is now coming down. And again we repeated at 8 months. So this report just came almost half an hour back, and you can see now that it has almost gone lesser than normal. It is almost like lower limit. So this is the another problem that we have with the newborn screening. So this is a disease where the treatment has to be lifelong, and this child actually comes from a very far off village. It's not very near to AIIMS Kalyani, almost like 200 kilometers away. So the parents tried to contact other pediatricians of the village, but they were unaware of the disease, and they were telling that they are not very happy to manage that. But if the child comes again and again traveling 200 kilometers, then there is higher risk, and with a like a train or other bus, then there is a higher chance of infection, which we want to prevent. So that is the problem, that the more pediatrician and neonatologists, they should be actually aware of this disorder, because the treatment is very straightforward. And the today's report, it is showing that other carnitine level, the C10, from C10 to C16, all the carnitine values are low. So now the child has to again come back to us, and we have to increase the dose and again titrate the dose. So for this particular disease, the family as well as the doctors, they have to have very high morale so that the child can be screened so many times. And the other important thing is that whenever the child is having a febrile illness, then a emergency protocol has to be instituted. So the emergency caregiver should know that what are the things that should be done. And there is a French network which is known as the G2MC. So in their website, actually, these kind of cards are available for many rare inborn error of metabolism, where we can immediately find out what is the emergency treatment protocol. So that is very important, I think, for these diseases. So this was, I think, a good example of a better outcome of newborn screening. This is another child where there was no newborn screening done. At 11 years, the child came to us. Actually, the child came to psychiatry department, child psychiatry, with global developmental delay and hyperactivity. But the child also had history of seizures. So because the child had some features of autism, the child was referred to a genetic clinic, and we found that the child was unusually fair in complexion. The child was much more fair than either of the parents. So as we know that the melanin synthesis requires tyrosine. So the children with phenylketonuria, they have very high chance of fair complexion and all other features that this child had. So immediately we sent for again tandem mass spectrometry, and we found that the phenylalanine level is very high and tyrosine level is low, which is explained because if the phenylalanine cannot be converted because of the phenylalanine hydroxylase deficiency, then the tyrosine level will be low. But this child also had a low glutamine lysine level. So at that point of time, we didn't know what is the cause, and we didn't find what is the cause. So the child was put on this PKU1 diet, which is manufactured by a Bangalore-based company. So the cost is around 3 to 4,000 rupees per 400-gram jar. So the cost has also come down. So that the dietary therapy with a low animal protein diet and plant protein based diet, along with the supplementation with tyrosine and this PKU diet was started. But even after 6 months of treatment, only improvement the parents told is that initially the child hair was light colored and now it has become like pitch black. But other than that, cognition wise, there was not much improvement. Some degree of decrease in hyperactivity was there, but the treatment was not very optimal. So definitely it was a failure. So if this child was diagnosed at much earlier age, all this problem could have been averted. So the question remained that why the glutamine was low in this child. So I'll come to that in a moment. So the genetic test also was done and it was actually confirmed that the child has a truncating mutation. So the glutamine level here was low because of the degradation. So when we send samples to NIMHANS, previously we were sending without a desiccant and without a Ziploc pouch. So that is causing all our samples to have low glutamine level because of the sample degradation. So now we are sending in a Ziploc pouch along with the desiccant, and with that we are getting good results. Now I'm coming to the last part of it, that is how we can know that what is the burden of this rare metabolic disorder. So based on our publication, so these are the some estimates that we have, that worldwide 1 in 3 of people is a carrier for a rare inborn error of metabolism, and 5 in every 10,000 newborn is affected with a recessive inborn error of metabolism. Few population have very high prevalence. For example, Ashkenazis, Jews, European Finnish, etc. In South Asia, the population frequency vary very significantly. For example, certain population in Andhra, the prevalence may be much higher because of consanguinity. Even some other parts of the country, it can be high. But as per our estimate, at least 8,000 or more newborns should be born every year in India, where they are with a disease which can be easily screened and treated with very minimal cost. So that is something we are missing, as we are not having a universal newborn screening program. So this is a little bit in detail what we did. So we took the data from the Genomedi database, and we actually extracted the variants and we filtered the variant based on the pathogenicity. And from that, based on the Hardy-Weinberg equilibrium, we estimated the carrier frequency as well as the affected frequency. So as per our Genomedi data is actually an American database, and those South Asians who are living in America, their data is there. So it is not very representative of our data. And now we have Genome India data, and we are trying to get funding to use those data to do the same kind of analysis based on the Indian data. So that will give a much better estimation of the burden in Indian population. So till now, whatever data we have based on the American data available, these are the top disorders which are there. So first one is definitely the congenital adrenal hyperplasia, which is confirmed by the other ICMR studies also. Then we have homocystinuria, serotonin, xanthomatosis, methylmalonic acidemia. So those disorders can be treated easily with vitamins and other steroids, etc. Then you have storage disorder where the cost can be much higher. And then there are amino acid disorders or other storage disorder. Biotin deficiency again can be treated easily with vitamins. So some of those disorders are easily treatable, other the cost is much higher. So this is how we estimated. We multiplied by that annual live birth rate. From that we got the estimate. So the tragedy is, though it is preventable, we are not able to diagnose and treat. So we need to generate more data. We need Indian database and use that database to justify more that we need a nationwide newborn screening program. And the policy makers and government should be made aware of those. The capacity and infrastructure should be made, as well as the public awareness should be made. So WARDI has a leading role in that awareness in both the public as well as the healthcare as well as the government and policymaker level. So I think WARDI can play a large role in expanding NBS throughout our country. So with that, I stop sharing my screen. Thank you.
Thank you, sir. Thank you so much for such a comprehensive, elaborated lecture on NBS. Why I am emphasizing on the word comprehensive? Because we have got already 8 questions from the audience, and it is just increasing with time, the number of questions. So, sir, without further delay, I'm proceeding with the questions,
Sure,
and
tell
all
me.
these questions are from audience only. I'm
All
not
right.
generating in my mind and asking you, sir. It was so comprehensive. We know the lecture is good when people understand and ask questions to us. So it is here, sir. I am asking one by one. The first one from Kasif. What about career screening for each newborn? What do you think? How it can impact on health of babies?
I think it is an excellent question because this is already underway in many of the Scandinavian countries. So, for example, in Denmark, Sweden, etc., there every newborn is undergoing a whole genome sequencing. But in India, that will cost around 70,000 rupees, I think, per in every newborn. And not only it will be a career screening, but it can also be like a screening for all disorder, which will be adult onset disease also. So that is the problem of genomic testing, that there is a hidden burden where we cannot predict based on today's information available that what are the effects of all the variants which are there in the genome. So there are two-pronged problem in that. One is definitely the cost is very, very high, where every newborn, if you want to screen for all disorders, even for career status, but definitely if you want to look at whether they are affected or not. So there is another very fruitful area of research, that is the screening of all newborn who are admitted in ICU. So it is estimated that at least 1/3 of the newborn who are admitted in NICU have a genetic disorder, which is treatable. So now the medical fraternity is moving towards a expanded whole genome screening for all newborn who are admitted in a NICU in a very time-bound manner. So maybe the report will come within 72 hours. So maybe within few years will even in our country will come to that level where all the newborns who are sick will be undergoing whole genome sequencing to easily diagnose the disorder and treat that disorder.
Thank you, sir. Thank you for your answer. In 2025 January, there is a paper from that Guardian project. They have said that metabolic diseases, the sensitivity is 80.3% when they are doing that genomic newborn screening. So, and sir, one question I'm just asking because I know there are a lot of questions, just one from me. That sir, as spinal muscular atrophy, that is now fulfilling that Wilson-Younger criteria because it is accepted treatment is there, and this is an important health problem of India. So whether uh, we should ask the government, request the government to include it in the newborn screening panel.
Absolutely. I think some of the drugs like Risdiplam are now available and manufactured by Indian companies. So definitely it actually fulfills the Wilson and Younger criteria.
Yeah.
It is definitely fulfilling. And as per my reading, the highest prevalence of genetic disease in West Bengal is of beta thalassemia, which is there in 8% of the population. And SMA, it is almost like 1 in 40. So it is 2.5 per 100 population. So carrier status for SMA is not very low. I think it is slightly lower than thalassemia, but it is not extremely low. So definitely it should be screened because the gene therapy cost is so high. It is locked in crores. So definitely it should be screened in the population.
So coming to next person, Deepika T, is there any open source data for NBA's statewide programs implemented? Would you suggest WGS for all NICU newborns?
Again, the cost will come. So ideally, I think based on the available data which are published, there are a few papers in NEJM also within last few months. So definitely it is worthwhile doing whole genome. And I think maybe some of the top hospitals in a private setup, they are already doing those in our country also. But till now, because of the cost and the time that it has to come within 72 hours. So, and other kind of sequencing facilities like long read sequencing facilities, etc., they are not easily available in our country. So I think few years, we require a few more years. By that time, more information will come and the cost of sequencing will come down. And the spot read sequencing can also be modified so that it can also give long reads. So that way, within few hours, I think few years will come to that level where it will be cost effective for our country.
Thank you, sir. Question from Mr. Vikas Bhatia. Can Kerala model is good for starting universal newborn screening in other states?
I thank you, Bikasji, for attending this session. So, Bikasji actually had come to our institute few months back, and here also we had a CME on the NBS. Thank you for the question. So, I think Kerala is leading the way for healthcare throughout our country. That is undisputed. And if you see the Goa model and Kerala model, these are actually the opposite. So, Goa started with a 50, and now they have come down to, I think, 5 or 6. So, I think the Kerala model is better, where we start conservatively and then we expand. So in Kerala model, initially they started with few hospitals. Now they have expanded to all government facilities, and after that they want to expand to all facilities, both government and private. So that is the thing, and based on the data that the Kerala government is generating, that is the eye opener for all government who are there throughout the country. I think that is what we should follow.
And sir, the popular like in polio, do boon zindagi ka. Here in NBS also they have proposed that hill to hill.
Hill to hill, yes.
That was very catchy.
Hmm.
Lot of questions, sir. Mr. Bikash Bhatia, another question. How many children born with metabolic disease in our nation every year with hearing loss, with heart defects, with congenital hypothyroidism?
Yeah, so congenital hypothyroidism, I told that around 1 in 1,000, it is like that. Congenital hearing loss is around 1%, so it is very high, congenital hearing loss. And the third one, what sir was asking? I think critical congenital heart disease. So again, 1% of the newborn will have some kind of a heart defect, but it may not be critical. So exactly, I do not remember the critical congenital heart disease, how much. I think it will be around 1 in 10,000 or something like that. But the PFO, like persistent patent foramen ovale, etc., these are much more common. But critical congenital heart disease is slightly less common than that.
Thank you, sir. From Mr. Nadir Aman. When a test comes back positive, parents are terrified. In Indian clinic hospitals, we lack a genetic counselor on hand. How do we handle the fast, scary conversation so that the family stays calm enough to actually follow through with the next steps? I think, sir, we should have a NBS test because we need that informed consent from them, and they have the independence to choose it or reject it. So we should
Absolutely.
give that before and after. Sir, Nadir needs your comments on this.
Yeah, as Madam has told, and I like to add that one particular story I need to give. So there was a very famous gynecologist. There is a famous gynecologist in Kolkata, and his own newborn, there was a diagnosis of glutaric aciduria. So glutaric aciduria, the child will have macrocephaly, and there will be definitely the MRI change in the neurosonogram also, even after birth. And there is a high risk of seizures and other movement disorder. So the gynecologist were very alarmed that this has come, and it came from a reputed lab actually. But the sample was sent far away from Kolkata. It was going to Delhi, and the report came back. And I told that because of the humidity, there can be degradation of the sample, and other because of the collection, how we are putting the drop, it can be both false positive and false negative. So I told that you should ask the lab that how confident they are, and if they need that, the test should be repeated or not. So when the lab was contacted, then they told yes, we are not very confident, and the test should be repeated. And the repeat result was absolutely normal. There was nothing in that. So we should counsel the parents also that false positive can be there, and it is expected because it is a screening test. It is not a definitive test. So if it is a positive, then you do not need to panic because all those diseases which are being screened, there is a treatment for those. So we can treat definitely. So once we confirm it, either by repeat test or by genetic test, then definitely the treatment can be instituted.
Thank you, sir. Another question from, no, the first question from Dr. Kutlu Bhattacharjee. Do you think preconception couple carrier screening genetic can help in increase the awareness of NBS, since parents will already have idea about the variant they have, though not every couple will be carriers?
Yeah, so I can give the example of thalassemia. So in West Bengal, actually, the population are very mindful about thalassemia, and the government programs are also there where in the school children they are screened for thalassemia. But I request you to look at uh, the matrimonial page of the newspaper. So you will never see that anybody is declaring that he or she is having beta thalassemia carrier, and they want another match where the match is not having thalassemia. So the government program is actually going on, but it is not effective because the parents, the couple, if they know also, they are not looking for another match where he or she is not a carrier. So the answer is actually the preconceptional career screening. That is the most important thing. So before marriage or even after marriage, before conception, then definitely at least the beta thalassemia and also the SMA. These two should be screened. So for all preconceptional counseling, I tell about these two, thalassemia and SMA. And because of the sequencing cost has come down, so with another 7,000 rupees, actually we can screen for many other disorder also, where we can screen for many other disorder. But we should keep in mind that we cannot screen for all disorder because many uncertain significance variant will be there. So the counseling part is very important. So sometimes they will be alarmed that we have so many variants and so many. So if they are worried about the uncertain significance variant, then they will not have any child because every child they have, the child will have some uncertain significance. So again, the preconceptional counseling, pre-test counseling, after test counseling, all those are very important.
Thank you, sir. Shubham Banerjee. Dear sir, as a practicing genetic counselor in the rural part of Bengal, the biggest challenge is awareness among these states, even in the clinicians. The need for NBS is still misunderstood among many of the people, as the number of GCs and MGs are very less, and the rural and peripheral areas are almost lacking in any such facilities. Hence, please guide us on how we can accommodate NBS in the rural hospitals, nursing homes, and other facilities at bearable expense.
So the newborn screening always does not require a biochemical test also, because the hearing screen as well as the critical congenital heart disease by pulse oximetry. So these can be easily done actually, but little bit of instrumentation is there. So at least the block level, if the block hospitals, they have the newborn hearing skill equipment, and the pulse oximetry should be there in each PHC. I think all the primary health centers should also have the pulse oximeter. It is very cheap because during COVID, all of us actually bought our own pulse oximeter for our own screening. So many people are having the pulse oximeter. So at least the pulse oximeter should be done in all the newborns. Second is the hearing screen is very important. Third is the cord blood TSH. So that can also be very easily done, because TSH test is available in all nook and corner of West Bengal and the country. So these three should be at least screened. These three should not be missed by anyone. If we miss either of these three, that is something that is not very understandable. So everybody should be screening for TSH, hearing screen, as well as the critical congenital heart disease. For the other, like GSPD deficiency, the enzyme assay may not be easily available everywhere, and biotin deficiency, congenital adrenal hyperplasia. So they are actually the district headquarter or the state headquarter. There has to be a referral system, so that from the government hospital they reach a particular lab, and that way the report can be given. So this is actually the Kerala model, like a hub and spoke model. So there is a hub hospital, from all spokes the sample comes and the report gives. So throughout the world, the newborn screening is like that model only, hub and spoke model. So in our state also, the state government has started hub and spoke model for telemedicine management, telemedicine, teleconsultation. So the same model can be used for applying newborn screening also, I think.
Thank you, sir. Question from Dr. Brijesh Kumar. We can also do the study for hemoglobinopathies by using the DBS method.
Yes, in the DBS method, we can do. Only problem is that because there is a fetal to adult switch will be there, so the fraction of fetal hemoglobin will gradually go down. But there are definitely cutoffs. So even from the dried blood spot also, both by HPLC method as well as by genetic method, the hemoglobinopathy can be screened. Sickle cell anemia to be specific.
So many questions. Another question from Shucheta. What strategies can improve awareness and acceptance of NBS?
The same thing, the polio, I think, do boon jindagi ka. So that kind of a mascot we need, and we need government policy, so that unless the government, I think government has to give a push. Unless the government has a national program, this will not go on. The more problem is that because of the diversity among India, so the program cannot be a one size fit all. For example, in West Bengal, everybody needs to be screened for thalassemia. In Odisha, Jharkhand, they should be screened for sickle cell anemia. In Andhra Pradesh, they should be screened for inborn error of metabolism. So, based on that data, the different state governments should have different policies, similar to which is there in US. There are also different state has different policies. It is not the same policy throughout the country. And then only once the policy is there, then only the rest of the thing can follow.
So whether, sir, in India, uh, we shouldn't follow a universal screening pattern. We need to have a state specific or high risk population specific screening in newborn
Yes,
screening.
universal can be there for these five disorder, like the congenital
Mhm.
hearing loss, hypothyroidism, etc. But for the other one who does not have so much of frequency and the cost is little bit higher, so at least these five or six, it should be universal. It should be free of cost to every child. And then if the high risk, the second tier, like the National Newborn Forum, the second tier, the high risk newborn, there the expanded screen should be there, where 20 to 50 disorder can be there. So that should be available universally for the high risk program. Now, for some state, they can expand those universal five. They can expand to 5, 6 to 10 like that, based on the program. So at least one universal program should be there, and further things can be added state specifically.
From Mr. Vikash Bhatia, written here in summary, newborn screening save lives. Do as a program in every child care center.
Yes.
Dr. Irfan Vora, how is the prognosis of beta ketothiolase deficiency and any special treatment plan other than carnitine supplement?
I think beta ketothiolase deficiency is where the child is unable to utilize the ketone bodies. Once it is the child is having fasting, then the glycogen store is depleted, then the fatty acid oxidation is happening, but the ketone bodies are not getting utilized. So carnitine may not be useful in this particular disorder. And the main important thing is that the hypoglycemia needs to be prevented because the beta oxidation cannot be used. Problem is that the heart, even during fed state, the heart depends on fatty acids. So I think the child will have risk for cardiomyopathy. Even if we prevent hypoglycemia, so there will definitely be a risk of cardiomyopathy even if the child is given all possible treatment. So it is not entirely treatable as far as I recollect now.
Thank you so much, sir. You have answered so patiently with all the questions I am asking you from the audience, and with time they are asking different questions. So, sir, when we know that in first baby or previous child we had a genetic situation for metabolic disorder, whether we should prefer the prenatal screening if it's a pathogenic, likely pathogenic variation which is evident to cause the disease and life impairment, which we can prevent through early screening, through if we can take the steps very early just after birth, whether.
Yeah, so this is like a debatable situation. For example, the case I discussed here, that it was diagnosed prenatally, but the parents wanted to continue the pregnancy. They knew that there is a chance that the child can develop cardiomyopathy, and during a sickness period, there can be sudden death also. So it is actually a call that will be taken by the parents. So our job is to give all the information and support them. So, for example, if prenatally SMA is diagnosed, then there are 5 types of SMA, like 5 or 6 types from 0 to 5. So, some of them may not be very severely affected, and we always cannot predict it. But if the SMN2 gene copy number is high, for example, 6 or 7 copies, then you know that it may not be so severe. And definitely, the gene therapy cannot be promised for everyone, but other therapies are there. So, if the parents think that maybe they were having difficulty in having a child and it was a very precious pregnancy, so if they want to go ahead, then it should be left to them. So it is their choice basically. They want to, even after the
Yes,
child
sir.
is diagnosed, it is their choice.
Their decision, their autonomy should be there in the decision. But before that autonomy, we need to explain all the possible options and their outcomes.
Yes.
And that we can do it by counseling only. So we need a more and more patient, compassionate genetic counselors throughout India, and persons who are efficiently can do the counseling to the people. Thank you so much, sir. I think we need to close the session now. We have learned a
Okay.
lot from sir. And if any one of the audience, you are having any question, you can write in the LinkedIn page of ORDI, you can message. We'll communicate to sir. And I think sir will help in answering.
Definitely. Definitely.
Okay.
Thank you.
Thank you so much. Thank you so much.
Thank you. Thank you.
Thank you very much, sir. Thank you, Dr. Emili. It was a great session. And if anyone has queries, you can directly write to info@ordindia.in. info@ordindia.in. Thanks again. Thanks, audience. Thanks for making this a good event. Thanks.
Thank you.